Welcome to Healthy Focus, the Duke Rawlings Hospital Community Education Series.
Thank you so much for that introduction, and thank you all for making it out in the stormy weather. I was kind of concerned. I thought maybe it would scare some people off, but it seems like we've got a pretty full house. So, just to start off, pat yourselves on the back for coming out and being willing to open your eyes and ears to a couple of different points that I hope to cover today. So like Mandy said, my name is Amie Kawasaki. I'm originally from Miami, Florida, so the rain is kind of part of my MO. The snow, however, that one threw me for a loop. That one was really tough. So without further ado, I'll get started, but today's Healthy Focus is just going to be on urogynecology, and that might be a pretty new term to some of you. And I wouldn't be surprised if it were a new term because it's a rather new specialty. And it's a specialty that was birthed out of really people who are interested in looking at the pelvic floor and pelvic floor disorders in a different light. And so our specialty is comprised of a lot of different kinds of physicians, mine being a background of obstetrics and gynecology, followed by the urogynecology fellowship training. So let's get started with just understanding what is urogynecology. The actual specific term, if you're looking for the board-certified specialty, is a mouthful. It is female pelvic medicine and reconstructive surgery. And so, when you look at this title, I want to just sort of highlight that it's female pelvic medicine and reconstructive surgery. So it doesn't mean that everybody who walks into my office walks out with a scar, okay? There's a medical part to this. There's a part that requires conservative measures and lifestyle changes. You get homework out of this. You don't just get a recovery period after a surgery. However, surgery is also a big part of our specialty. And so what we do as urogynecologists is we specialize in pelvic floor medicine. We specialize particularly in the treatment of pelvic floor disorders and in advanced pelvic surgery. So some of the conditions that we treat are conditions that I won't cover today just because they're very, very particular conditions. But those surgeries, such as fistula repairs or urethral diverticulectomies and things like that, are under our realm of specialty in the advanced pelvic surgery. So who does female pelvic medicine and reconstructive surgery? Like I said, it used to be sort of a special interest that somebody would develop, and those physicians and surgeons generally came from either gynecology or urology. So many of you have probably had some of these conditions evaluated by a urologist or a gynecologist, and there's no wrong way to do that. It just means that that particular urologist or gynecologist had this interest to study. Like I said, it's a newer field. It's not that we're just learning about these things. It's that we finally became aware that these are such common disorders and there are so many different treatments that it's been recognized that we should make a formal subspecialty out of this. And with that formal subspecialty, we have formal training, we have formal board exams, we have very formal particular things and guidelines that we need to follow now. And so at Duke Urogynecology, all of our urogynecologists are GYN trained, we're gynecology trained. We do also have 2 urologists who do female pelvic medicine as well. They're just not part of my office group. They're in Raleigh as well. So we have Duke Urogynecology and then Duke Urology with the female subspecialty. In order to get into the Duke Urogynecology program, you've completed 4 years of obstetrics and gynecology. And then as a subspecialty trained urogynecologist, you do 3 extra years of female pelvic medicine and reconstructive surgery. And so it's a long road, but it gets you to a nice specialty in the end. So let's get down to the heart of matters. What are we here to talk about? In general, the female pelvis. The way we used to look at the female pelvis is we used to divide it into all of these different specialties. And so over here in purple, in dark purple, you'd see the rectum. And the rectum was the world of the gastroenterologist and the colorectal surgeon. The uterus and the vagina was always the realm of the gynecologist. The bladder was always the realm of the urologist. But everything that was held together and held up by the pelvic floor, well, who's responsible for that? And so when you really start thinking about what our specialty does, It tries to it tries to focus on these different disorders and look at the pelvic floor as a functional unit, right? We're not trying to silo all the organs into different specialties. That, however, does not mean that I am your colorectal surgeon, urologist, and gynecologist. That means that when we look at these different pelvic floor disorders, we look at all of these things in combination, but those specialties are still very important for their individual issues. So for example, I don't do your mammogram and your pap smear and then also take care of your bladder, right? So I don't do all of those different things, but when all of those different things come together to form a problem, then we don't just focus on our one little area. We look at the function of the pelvis as a whole. So let's go through what it is, right? What is the female pelvis and what comprises the female pelvis? And when I first started thinking about how to describe all of this, I came upon a lot of anatomy slides. And I thought, if I push all of these slides up on a screen and say, well, this is the female pelvis, let me introduce you to it, I think a lot of people would get really disoriented, uncomfortable, and confused, right? Y'all didn't do an anatomy course in gross anatomy labs, right? And so what I'd like to do is connect this to something very easy to understand, so that when you do look at these in the future, it's not so intimidating anymore. And so up on this side, you see the ribs of a basket, okay? You see the columns that are required to put together a basket. And that's what I would like for you to think of the bone structure of the pelvic girdle, okay? It's the framework. It's the scaffolding. The next layer of your basket is the lining, right? It's what allows you to put together a basket that doesn't have a bunch of holes. Things are not going to seep out of it, right? And so it's not just the framework, but now you've got another layer that kind of makes it a more continuous structure. And so that lining on the inside of the basket is what I'd like for you to think of when you think of the pelvic muscles, okay? So there is a layer of pelvic muscles that is on top and lining all around that bone structure, okay? And then finally, what's the use of a basket if you're not going to put something in it, right? And so the contents of the basket are the things that can also contribute to our disorders. And so in the female pelvis, we're talking about the bladder, the uterus, tubes, and ovaries as one big structure, the vagina, and the rectum, okay? So I hope that this deconstructs and demystifies a little bit about the things to think about when you're thinking about the female pelvis. I also want this to highlight the fact that the muscles are a very important structure. They're the second big part of the structure of your pelvis, and they are very, very often forgotten. And so when I throw up these pictures next time, or if you open up a handout or something and you see these kinds of images, bring back that image of the basket. That's what your pelvic floor is. That's what your pelvic girdle is. It's the ribs of the basket. The muscular floor is that ribbon that makes everything continuous, and the contents are what lie inside, okay? So, like we said, bones, muscles, ligaments, and connective tissues. That's your pelvis. What's held inside and supported by these structures are the bladder, the uterus, the vagina, and the rectum, okay? And so, now that we've been introduced to the pelvis itself, let's talk about some of the disorders that can plague the pelvis, okay? And starting off with pelvic organ prolapse. Now, I put these images up here for a reason. They all have a pretty important theme. Everyone's embarrassed, no one's talking, and nobody's actually raising their hand and saying, oh yeah, that's me, right? Nobody talks about these things. Nobody wants to bring this up over the dinner table conversation. Nobody hangs out in the washroom while they're putting on their makeup in front of the sink and talks to the stranger next to me like, yeah, I almost didn't make it to the bathroom today, right? We don't talk about these things because we're embarrassed. But honestly, it's one of the most common conditions that face us. And so, among the pelvic floor disorders, there are several. I'd like to focus on the top two today, which are pelvic organ prolapse and urinary dysfunction, although all of these disorders are things that we do treat as urogynecologists. How common is this? 1 in 3. Maybe more in this room because you actually came here for a reason, but 1 in 3. You're walking through the grocery store, you're standing in the airport, you're sitting in church. 1 in 3 of you women have a pelvic floor disorder in your lifetime. That's how common this is. So the fact that nobody talks about it is unbelievable to me. The most common time frame that my patients report to me that they've had these problems before they came to see me, anywhere between 5 to 10 years. People think back and I say, how long have you had this problem? Oh, well, how old is my daughter now? Unbelievable, right? And that's not to say that the moment something happens, you need to come rushing in to see me. Not at all. But the moment it becomes bothersome, the moment it starts to change your quality of life, that's when you should come see us. That's when it's something that is intrusive in your life. And that's when it becomes a disorder. And so 1 in 3 women in their lifetimes have a pelvic floor disorder. Just because it's common does not mean it's normal. Just because a lot of people have the condition doesn't mean that you need to suffer with it. There are things that we can do about it, and that's what we'll cover a little bit more now. So, starting off with pelvic organ prolapse and the dropped vagina. I put in the word dropped vagina, but that's not the most common word people use. People tell me all the time they have a dropped bladder. And I want to dispel the myth of the dropped bladder. The structure that is actually the supportive element that is seen when things drop is the vagina. What's behind that structure may be the bladder, it may be the rectum, it may be the uterus, it may be the small bowel. Everyone blames the bladder. Everyone comes in and says, I've got a dropped bladder. No, all you're seeing is the vagina that is herniating, and that is what the prolapse is. What is behind the vaginal wall, that's what's my job to determine and tell you, okay? So I changed the word from dropped bladder to dropped vagina, because that's what I would like for you to think of this as, okay? Don't blame the bladder, it's just the innocent bystander, okay? And so let's talk about the other things that can prolapse, that can fall out of the pelvis. Pelvic organ prolapse. Most of the symptoms are a vaginal bulge or pressure. Why is that? Because there is something falling out of the pelvic floor. We talked about those muscles, right? We talked about the bones. The bones don't really go anywhere unless you have a terrible accident or a fracture or something like that. But for the most part, bones don't go anywhere. It's the muscles, the ligaments, and the connective tissue that change. And so that woven part of the basket, that's what can change so that things can fall through, okay, or herniate through. So what patients will say is that they'll have this vaginal bulge or this pressure sensation in their pelvis. Generally, by the end of the day, it's worse. Why is that? Well, because gravity's been working on us all day. In the evenings, we lay back, we lay down, and things kind of settle in their place. But when we stand up on our 2 legs, gravity tends to push everything down onto the pelvic floor, and if that pelvic floor has a weakness in it, well, that's exactly where that herniation is going to come through, okay? And so worsening by the end of the day just means that you've been walking around a lot. You're just sitting upright. You haven't been laying in bed all day, okay? Oftentimes, that can also present as difficulty urinating or difficulty passing your stool. That's not because the bladder is bad or because the rectum is bad, but because of the change in the anatomy that happens when things fall or herniate through the pelvic floor. So let's talk a little more detail. So over here we've got the normal anatomy, right? We see here the bones, right, the ribs of the basket. We've taken off the layer of the muscles just so that you can see the inside of the basket, okay? And so we've got the vagina in the middle. The vagina is the most important thing in our pelvic floor for the purposes of this talk, okay? The vagina is key. Get comfortable with it, okay? Get comfortable with the word vagina. It is A-okay, okay? So the vagina is central in the pelvis. In the front is the bladder, in the back is the rectum. On the top is the uterus. So when we think of the vagina, there are 3 compartments to the vagina. The anterior or the front compartment, right? That's responsible for keeping the bladder in place. The posterior or the back compartment, that is responsible for keeping the rectum in place. And the top of the vagina, which is responsible for either keeping the uterus in place if you still have a uterus, or if you've had a hysterectomy, keeping the top of the vagina or the top of that tent in the correct location. Okay, so the 3 compartments of the vagina. What happens when pelvic organ prolapse affects one of those compartments? Well, this is the condition called a cystocele or an anterior vaginal prolapse. Anterior, the front wall of the vagina, has lost its support. So this poor bladder has dropped into that area. Again, innocent bystander, the vagina is the floor to the bladder. The floor has fallen out from under it. So the bladder follows out that area. It's like the trap door has swung down and the bladder just sort of falls into that open space, okay? And so in this picture, this person would say, I have a bulge coming out of the vagina, okay? What's behind the bulge they may not know. What may happen is by the end of the day, or as their bladder gets fuller, that bulge can get bigger. And when they empty their bladder, that bulge may get smaller. Or they may say, you know, sometimes I have to push on this bulge in order to empty my bladder. Well, why does that make sense? Because if you look at the opening to the bladder over here, which is the urethra, you've got a kink. So when the bladder is sitting in the right location, the urethra empties it nicely. When the bladder falls, there's a kink in that opening tube of the urethra of the bladder. And so it's harder for people to empty because they have to push in that bulge to straighten out the kink in the urethra to empty the bladder. And so that's the component of having more difficulty emptying their bladder when their prolapse is bad or when their bulge is bigger. This is the same condition can happen on the back wall of the vagina. We call that a rectocele, okay? Or a posterior vaginal prolapse. The back wall of the vagina has lost its support over here, and so the rectum finds all this new space it can fill up, and it falls into that new area or that new space. Same thing can happen here with stool trapping, right? The rectum is sitting up here, the anus is the opening to the rectum, and so the stool travels, it gets stuck in this little cul-de-sac almost, this little hernia pouch. And so people are pushing to have a bowel movement, but the contents of the bowel movement are not traveling in the same direction that they used to come out of the anus. And so as the bulge gets bigger, as they get more stool trapped in that area, sometimes they need to push it back inside in order to empty through the anus, okay? That's the front wall we talked about, the back wall we talked about. Now we still have the top of the vagina to address, right? The top of the vagina, if you still have a uterus, can present like this. The uterus and the cervix, which is the opening to the uterus, it's all one structure, can herniate through that space, and so what comes down could actually be the cervix and uterus itself, okay? So you may be able to see or feel something very firm, that's generally the cervix. If you've already had a hysterectomy, same thing can happen, but only the top of the vagina is what comes down, okay? Ultimately, would you know that you have one or the other? Probably not. What you would see if you had one of these conditions is just a pink, fleshy skin coming down in the opening of the vagina. And then we would try and talk you through what it is and which compartment and why it's important and how it attributes to your symptoms. Okay? So we're breaking down a pretty difficult concept into some pretty simple and basic ideas. Now, how do we fix this, right? It kind of depends on how bad it is. If we're just talking about the beginnings of prolapse, if you are getting a routine exam and your physician says, you know, you kind of have a little drop in the front vaginal wall, should you get alarmed? No. If it doesn't bother you, you don't need to get alarmed. The interesting thing about prolapse is it doesn't shorten your life. It doesn't change your life expectancy. The time that I get involved is when it changes the quality of your life. When that bulge bothers you because it rubs on your underwear. When that bulge bothers you because you can't empty your bladder or your bowels. When that bulge bothers you because you can't have comfortable intercourse. That's when I get involved. But if the bulge happens to be there and a physician happens to mention it and you have no idea, it is not anything that needs to be addressed. So you don't need to be alarmed about it, okay? One of the non-surgical options that we can discuss when things are just there and you say, well, now that it's beginning, it doesn't bother me, but is there anything that I can do to stop it from getting worse, right? What are the preventative measures that I can take? Well, one of the first things you can do are pelvic floor exercises. How many of y'all have heard of Kegels? Everybody. I get this all the time. I do Kegels all the time, Doc. Well, that's good. How many of you had a tutorial on how to do a Kegel? Right? So somehow or other, it was understood that just because we're women, we all know what a Kegel exercise is, inherently. Like we should just know. We're born with that right of knowing what a Kegel is. Well, I'll tell you, after having done very many exams and asking a woman to Kegel, oftentimes they're not. They're either not being able to recruit the right muscles because they have no idea what you're talking about. They're squeezing their butt, they're squeezing their abs, they're crunching, they're squeezing their legs together, they're doing anything, contracting anything in the hopes that they're contracting their doing their Kegel exercises. Or even the worst scenario is they're bearing down. And so when those ladies tell me, I do my Kegel exercises all the time, what you're doing is you're worsening the problem. You're bearing down all the time. You're effectively acting like you're constipated 24 hours a day, right? And so the Kegel exercise is it's a very important tool. It's a very important exercise. It's also really important to make sure you're doing the right thing. And so although people can say, I've been doing those for years, I make you prove it, okay? So when we're doing our exam, one of the basic things we do is we ask you to do your Kegel or squeeze or suck in so that we can get an idea of what the tone of your pelvic floor is and how capable you are of doing those exercises. So what happens to the women who can't do the exercises? Do I just say, ooh, that's too bad? No, we actually have physical therapists. We actually have ladies who are specialized in teaching you what it is to do a Kegel. Sometimes they can just talk you through it, and some of the words they use are sip through a straw, or lift, not so much a squeezing, but a lifting sensation, right? Talk about the core exercises. And so what we want to do is what's in this picture and this picture, right? We want to take the red ribbon of the basket, we want to get that lining and we want to suck it all in, okay? We want to increase the tone of the core and the bottom of the box. And what does that mean? So when we talk about our core, everybody knows what their ab muscles are, right? We all know what our abs are. We all want to strengthen our abs, right? Get those South Beach abs. We all know what our back is. But if you think of your abdomen and pelvis as a box, you've got the front wall, you've got your lats, you've got the back, right? What about the bottom, right? That's the pelvic floor. That's what's seeing all of that pressure and all that gravity all the time. But we're always so concentrated on this, we completely ignore the bottom, okay? And the top is the diaphragm. So if you wanted to think of the box of muscles that comprise your abdomen and your pelvis, okay? So things that we'll work on with you is either in the office we'll talk you through it, or if you need a little bit more help, we'll send you to one of our physical therapists and they'll teach you how to do your pelvic floor exercises correctly. The next thing that we do, if you say, you know, it kind of bothers me sometimes, it doesn't bother me all the time, I'm not prepared to make that big jump for surgery, or I'm not healthy enough to have surgery, or, you know, I might want to do surgery, but I've got a 3-month trip to Europe planned. So this is not really the greatest time, but I don't want to walk around Europe with this bulge hanging out. What are my options? A pessary. Pessary is one of the oldest options we've got. Pessaries have been mentioned in literally historical textbooks. Only they weren't made out of silicone and not this nicely shaped. They were made out of things like potatoes. But we've gotten a little bit more modern since then. And so pessaries are silicone or latex. This one's a latex one. The rest of these are silicone. They're structures that basically occupy space in the vagina. So if you think about it in terms of a hernia, right? We talked about a hernia. Hernia is easy for people to think of when it comes out here, right? And so an easy way, if something's sticking out this way, is to push it back in and put something tight around it. So I tell my patients to think about their pessary like a vaginal girdle, okay? It tightens, it pushes everything back in. That doesn't mean it'll cure you, because when you take off the girdle, everything comes back down, right? Same thing with the pessary. You put the pessary in, it sort of fills in the space of the vagina so the other organs can't push into that space anymore. It's a space-occupying device. When you take out that space-occupying device, all of the space happens again, that hernia happens again, and so the prolapse is still there. But this is a nice way to manage it, to get it out of the way for the interval time, okay? And that interval time can be weeks, months, or years. I've got some patients who just can't tolerate surgery. They just can't. Their doctors tell them you're just not healthy enough to go through anesthesia. And so they can use this for decades. And the way that we do this is you'll come into the office, we fit you like a pair of shoes. We try one size, we go up in size, we go down in size, we have you walk around the office, make sure it feels comfortable. It should really feel like it's not there. And so ideally, that's exactly what you want to do. We don't want it too small, we don't want it to fall out. We don't want it so large that it's uncomfortable to you. And once we fit you with the right size, depending on the shape and size, is how we have to manage it. Some shapes and sizes are small enough so my patients can take them out at night or out before intercourse. Some shapes and sizes are just too large for that, and so they come to see us on a regular interval, a couple of months, 3 months, 4 months, and we'll come change it, clean out the area, and put it back in, okay? So it's a nice option. Finally, when it comes to pelvic organ prolapse, we can talk about surgery. And surgery comes in a lot of different ways. So a lot of people have a lot of questions about surgeries, but when it comes down to it, to break it down into simple terms, we've got 2 ways of getting the vagina into its right place. Through the vagina or through the abdomen, okay? So either we do a surgery through the vagina itself or we access the vagina through the abdomen. Historically, that meant a large incision. With modern technology and laparoscopic assistance, now we're talking about laparoscopic or those keyhole incisions or the robotic technology using keyhole incisions. So that abdominal incision is a little more rare now than it used to be. But generally, that's the 2 ways that we do the surgeries. Which surgery we recommend depends on what kind of prolapse, how many compartments are involved, right? Because you can have 1 compartment, you can have 2 compartments, or you can have all 3 compartments involved in your prolapse. So depending on how bad the prolapse is in terms of how far out, and what part of the vagina is prolapsing is where we end up talking about the different ways that we can perform that surgery. Most of the surgeries we perform are same day or next day admissions. So either that same day you get to go home. 2 of my ladies today, I had one who went home the same day and I had the other who had to stay overnight. But those are generally the longest admissions that we have, is just overnight, okay? All of the surgeries, doesn't matter whether or not we use the keyhole incisions or the vagina, require about 6 weeks of no heavy lifting. But that's not to say that you're bedridden, okay? Quite the opposite. I want you walking. I tell my patients, you've got 5 things you need to do. You need to walk, you need to pee, you need to poop, you need to eat, and you need to move around, okay? That's all I want you to do. No heavy lifting in that though, because we've pushed